So welcome to the next episode of Endoscopy Essentials, and welcome to Mette Kalager from Oslo, from the Department of?
Health and Society.
Health and Society.
Yeah.
We have a very special topic, Mette, today. It's about evidence in endoscopy.
Yeah.
We are reading studies, and a study tells us, but people mostly read the abstract, and we want to take a much deeper look.
Yeah.
You're training, however, as a surgeon.
Yeah.
How comes that you went away from surgery and took the broader perspective?
Ooh, that's a very good question. I think it started when I was doing my training in breast cancer as a breast cancer surgeon, and we were the county hospital where I was working. And in Norway, back in the days, the hospitals were owned by the counties. It's a little bit different now, but this was the fact back in the days. And the different counties in Norway started mammography screening. And I was part of that. I was working at that surgical department at the time when the screening program started. And almost from one day to the other, we started doing multidisciplinary teams. We were discussing the patients, the outcomes after the biopsies. We had dedicated surgeons taking care of the breast cancer patients. Prior to that, it was more or less in the morning meeting like, well, we have 3 mastectomies, who are going to do that? And who is available for doing that? No discussion. No discussion beforehand, no discussion after. And this changed when we started.
Because there was so much uncertainty in some cases, or?
Why we changed
Yes.
it? We changed it because this was the requirements when we were going to be part of the mammography screening program. So part of that program is that you had to have dedicated surgeon, you had to have dedicated radiologist, dedicated pathologist, dedicated nurses, and also dedicated oncologists, of course, and we were all part of a multidisciplinary team, and that was a requirement for being part of the screening program. And seeing this as a young doctor, and of course, I was curious, and I thought, I wish if I was to choose, I would be a patient by the later regime, when you had all those teams, because it seemed to be such a big of a difference. Because on the multidisciplinary teams, we would discuss, is this the right biopsy? Did we do it correctly? Is this? Are we sure this is the thing we saw on the X-ray? And we were discussing with the pathologist, so it was really much more tailored to the individual patient. So, and the good thing was that all patients were treated differently, not only those who were invited for mammography screening. And then I got curious, does this really make a difference for the patients? Do, for example, survival increase?
So evidence starts with discussion.
Yeah.
So that
observation maybe, even so,
But discussing observation.
Yes.
And having different opinions, and then trying to find out. Yeah. And then you went away from surgery?
Yeah. So then, the curiosity was there, and I thought, I would like to investigate this. But of course, coming from medical school, doing everything I had to do in medical school, then going to surgery, which is a lot of practical work, as you endoscopists, of course, know. and that is fun. I mean, the artistic thing behind doing practical things are great. But then I wondered, I need to do more. I wonder about this. How can I study this? And I had no idea. I was never taught in medical school how to set up trials. I was not taught how to do observational studies. I had no clue. And then we moved from this county to Oslo, and then I was offered a position as the head of the mammography screening program in Oslo, in Norway, for the whole program. And then as a requirement for that position, they wanted me to do a PhD. And that fitted perfectly with my earlier observation and my curiosity about survival. Did these patients have an improved survival compared to patients that were treated previously to this regime changed or this change in clinical practice. So that's how I was sort of swept into doing academic medicine.
And who was training you then, being a surgeon and then all of a sudden having to have the oversight and analysis, etc.?
Yeah, no, that's an interesting and very bumpy road. So it started with me having those questions, and I couldn't even formulate the questions. I had no idea that you had to ask a specific question, I'm like, what do you mean? Well, does survival improve? Yeah, okay, that's kind of the question. And then at the cancer registry at the time was a statistical department or epidemiological department. And so I was set in contact with these people, and that's how we started. And pretty early on, I was lucky enough to get to know Hans Olav Adami. He's also an old surgeon, but he is more or less or more famous, I would say, for epidemiology. So he was associated with the cancer registry, and when I was working at the cancer registry, I remember one of the statisticians said, well, it's not really a good metric to look at survival. You should look at mortality. And I'm like, well, either you're alive or you're dead. It's kind of easy. I mean, what's the problems? And he didn't really, or I didn't understand what he was talking about. So, well, it's either this side of the coin or the other side of the coin. It's still the coin. Now, of course, I understand it's a big difference. I understand what he was trying to tell me, but I didn't really understand. And then I walked up to Hans Olav and I asked him, could you help me, or is there anything? And then he set into motion. He said, well, yeah, he was my main mentor. And then he moved to Harvard, and he was the head of the Department of Epidemiology at Harvard School of Public Health. And he said, well, you could, if you like, you could join me. And I thought, yeah, let's join you. So I joined him, took with me my husband and our 3 children, and moved to Boston. And then I was lucky enough, because Hans Olav is a trained epidemiologist, but I really felt like I needed more the statistical approach to it and the mathematical, because I kind of like math. And then I met Marvin Zelen, who is, I would say, the father of modern biostatistics. And I shared office with him for 1.5 years, and he taught me everything about early detection, mortality, survival, lead time, surgeon time, all those terms that you need in order to understand how you're going to set up trials and do observational studies when it comes to survival or mortality. So that's a long way.
And the whole process from leaving surgery to ending up in Boston was how long?
Ooh, I feel like the patients now that I ask, when were your children born, and the patients didn't remember, and I thought, oh my God, what an idiot. And I'm at that stage myself. Yeah, how long was that? 5 years maybe?
But that's very quick. I mean, this was a rapid change, dramatically. Yeah. And I think for our young viewers, the 2 pillars are curiosity and mentoring of the whole process, right?
And the third that I think is more important is having fun.
Yeah, which comes from the 2.
Yeah,
hopefully.
If you have a good mentor, you need to have fun. And this is another, I'm just going to say this story because it might be interesting. So there's Marvin Zelen, who is world famous, and for those who don't know him, look him up. He's really one of the great biostatisticians and builder of modern biostatistics. I asked him, I said, and I was lucky I shared his office, so I could talk to him about a lot of things. And I said to him, how do you choose your PhD candidates, or whom you're going to collaborate with? And I expected some elaborate, high-flying ideas. And then he said to me, well, you need to have fun. And I'm like, are you kidding me? And later, after years, I realized that that's important, or chemistry or whatever. You need to have some sort of, oh, this is fun to work together. Not, because mentoring people is not really telling people what to do.
Yes.
It's helping them, to give them some tools, and then you have to, like we're doing now, discussing, you have to go into the details, you have to understand, you have to be open-minded. And so I think that's the third pillar.
So, and the whole thing happened in one of those small American offices, right?
Yeah. Very small. I had a small, tiny desk, and he had paper everywhere. He was really messy, and I'm not so messy. So I asked him one day that if I could clean his office and throw away. And he said, yeah, just throw everything away.
If you have fun.
And his wife was like, oh my God, thank you so much. You're the first person that has ever been able to touch his stuff.
So talking about cleaning up, I think we nicely set the ground for trying to understand what kind of medical studies provide which type of evidence.
Yeah.
And of course, the holy grail is randomized trials.
Yeah.
Everybody says, randomized trial, level 1, etc., etc.
Yeah.
It has become pretty difficult nowadays. So, of course, it's logical that if you randomize patients, it's the highest level of evidence. But is there anything like, if you take the broad picture, that randomized trials have a longer duration in clinical practice than evidence based on, I don't know, whatever, retrospective trials, economic
data,
factors?
Well, I think it's always been difficult to do randomized trials or experiments. It's I would say the way I look at medical research is that you have experiments and you have observations. And a randomized trial is more or less a experimental trial. So it's an experiment, not an observation. And the reason why we do it is, to say it very briefly, is because it's easier to interpret. It's easier to understand what works, because you have 2 groups or 3 or how many that are supposed to be equal by chance, right? Because randomization means by chance. So by chance you get this treatment or that treatment or whatever. So it's easier to understand because they are the same. So it's not just me looking at you as a patient or looking at me as a patient, and we're not, we have different sex, we have a different age, and we have maybe different other habits or maybe socioeconomic backgrounds that may matter on the effect of treatment, let's say. So it's easier to interpret. That's why I think that is one easy way to understand why randomized trials are easier and more interpretable, more easy to understand the conclusions and easier to conclude with. And I think we should strive to do studies and trials as close to a randomized trial as possible. So I think if you want to do, we're talking now about treatment. We're not talking about basic science, right?
And we're not talking about diagnosis. Maybe
no,
we do that
so
later.
let's leave.
Treatment, endoscopic interventions.
Yeah, because it's easier to then be more to generalize. So you need to do something that's closer to a randomized trial. And when you analyze observation, let's say you have observations, think about, if this was a randomized trial, how would it been done? How can I analyze my data? What kind of methods can I use? So that's a good starting point, thinking and understanding, how do we do a randomized trial? And I also think that we cannot be too afraid of all the practical issues. And we are MDs. We are used to taking care of practical things. I mean, you have a patient, he can't move, or he's, the table is too small, his patients are too big. You find a solution to it. The same with randomized trial. You just have to push, you have to fight to do it. And then, of course, it's all the regulations and you need almost a professional person or people around you to just know how we're going to set it up. But I think you should aim to do randomized trials because it's easier. Although I understand they're cumbersome and we had this one trial and we included 100 patients and it took us close to 10 years, which is like an effort that you can look back and think, oh, it might not have been worth it. We'll see. We'll see about that. Maybe it's worth it. We'll see. But I think we should start there. And if there is no way that we can do randomized trial, then let's move on to the second best option, which is then observations.
Okay, but let's get back to the randomized trial, because if a randomized trial comes out, there are classical reactions.
Yeah.
So for example, surgery versus endoscopy, and surgery is not as good. There are people, during the discussions getting up and saying, the surgical group, the results are too poor. So for example, in my hospital, the mortality rates are much better, so I don't believe this trial. Or the same for the endoscopists.
Yeah.
What do you say?
Prove it.
Do your own randomized trial, right?
Prove it.
Yes, prove it.
Or just let me see your data then to see if your results are better. And you have to remember in a randomized trial, the whole idea is to get the difference between the two groups. So it doesn't really matter. Well, it may matter, of course, because I think this is important to discuss. If you have a trial where the mortality in the surgical group is maybe 3 times higher than what your impression or your knowledge is at your hospital.
Other complications, based on whatever.
Then you need to go back to the methods and understand, what was the inclusion criteria? Is this the same patient group? What can explain the discrepancy? So this is worth discussing. But it doesn't take away the fact that you are comparing 2 different treatments here, surgery and endoscopy. That's your example, right? So it may matter if your patient cohort is very different from what was included in surgery and also endoscopy. But if it's similar, you would expect that you will get the same results. So let's say you have a reduction of 30%, I don't know, maybe in pain or whatever you're measuring. It may be applicable to your population as well. But then you have to look at it. And of course, in order to have an experiment, the downside of most experiments is that you need to be very accurate. You need to describe what you're doing. Everybody needs to know what you're doing, because the main idea is really that you write it up so we have control over everything and that people can replicate it.
And you look under every carpet there is.
Yeah. And that is different from clinical practice, because then that's a valid point. A lot of patients will never be included in randomized trials because we think they're too sick or there's something about them that doesn't really fit or they don't want to participate. So that's the drawback, that you need to control it. It's a randomized controlled trial. And you could use placebo as whatever.
Yeah, that's the other big issue of randomized trials, that people say it may not be representative if you look at the patient population. And there can be a selection bias. Maybe we can talk about this a little bit, because there are obvious selection biases, but there may be hidden ones as well.
So, meaning when you talk about selection bias, what do you mean?
I mean, for example, if we look at some of the interventional studies in whatever hemostasis or EUS-guided biliary interventions, and you look at the number of centers, they're all high-volume centers, you look at the number of cases and the study period. And assuming what's not guaranteed, that everybody recruited during the same time, you end up with 3 to 5 patients per center in a year.
Yeah, okay.
So you say, what's happening? Where are the other 50? Or
I see. Well, then that I can't. Well, you can discuss it. You can look at it and you can say, was it something about the inclusion criteria that is, not representative of so maybe this is not selection bias. This is because selection bias would be if you select a treatment and then you compare that selected treatment with another treatment. So it's more about the representative whether the studies are representative or not, and they might not be, because they might only include, oh, this patient it's bleeding too much, we couldn't do it, or so that's important.
Well, this is a heavy bleeder, so he would be suitable for the new treatment, so let's randomize him.
Yeah.
Which is not allowed, but may happen.
Yeah, but once you're randomized, it's at random what group you get into. So unless you don't randomize, because once you randomize, you select people into things, but you randomize. So your chance of being in that group or that group, if it's 1-to-1 randomization, is 50% to one group and 50% to the
That's
other
right,
group.
but the bias may be that only the severe ones, which are potentially more suitable for the more aggressive treatment, end up in the study.
Yes. But then you have to look at the selection criteria, how or exclusion. It's either you select them in and then you have exclusions criteria, which is more or less the same. So if that is not generalizable to your patients group, you need then to start observing. You need then to think in your head, oh, these are much older, or these are younger than my patients. Is there a difference? Is there anything in the way I know the biology, or is there anything treatment, something special here? Then that's why we had doctors and not machines, because you have to understand who did that include, who did they not include? Are these people representative of the patients I have? And if not, maybe that trial doesn't give you a lot of information, because the trial is only what the trial is about.
But then I think that would be a killing criterion for quite a few of randomized trials. But I think from my experience, or my guess is that the most frequent selection criteria is time and money. And, usually the studies are heavily underpaid. They're not well financed. So centers say we will recruit, but then they can't, or they don't have the time. They forget it's 2:00. The nurse says, are you crazy? No study, go ahead. And,
no, so
how do we cope with that?
Yeah, no, that's a very valid point. So if we do believe that the highest evidence comes from randomized trials, we need to set up systems on the hospitals, financing the studies. So it's not up to the individual doctor to run around finding patients, because that's how it is now. That's the reason why we don't have a lot of patients in randomized trials, because it's too complicated. We don't have in our patients charts an option to randomize people or randomize people to different trials. We don't even know what trials are going on in our own hospital. We know of the one maybe in our department, but not outside that department. So that's one issue. We need to have this systematic approach to this, as we have developed for having patients charts. None of us could do medicine without having a patient chart. That's the standard, but it's not for randomized trials. We don't have the system. We don't even have platforms where we can randomize. You have to set up something extra. It's not within the same system. So in a sense, we're saying this is the highest evidence, and this country, at least in Norway, we are publicly saying that we have evidence-based medicine, but we're not doing enough to set it up. And then it's the finances.
So it's mentality and money.
Yeah.
But that would mean, if we take this a little bit further, that we are not prepared to do good randomized studies in the majority of cases, right?
No, I think evidence-based medicine, even though I think the first randomized trials were back in 1963 or something like that. So it's, well, I should say, I almost said it's young, but some people might not think it's young, but it's still a young field. So we need to give it more time. We can't say that this is the best and then say, because it's so difficult on the systematic level, that we're just going to dismiss it all. So I think we need to do more and influence.
To improve the conditions
I think that's where we need to work.
Okay, Mette, so much about randomized trials. I like your honesty. It's difficult, but the conclusion should be, don't give up, but try to improve the conditions. And Norway is a very rich country. The German Research Association has a budget of 1.3 billion per year, and very, very little
small,
goes into clinical research. So that's our plea, and thank you very much, Mette. We're coming back, and thank you very much for listening and viewing.